Hello, and a very warm welcome back to all you pharmacy professionals listening across Oxfordshire, Berkshire, and Buckinghamshire. We're diving deep again today, this time into something really central to the Pharmacy First service. We're talking about helping patients who come in with suspected infected insect bites. And just a quick note, this deep dive is supported by Community Pharmacy Thames Valley. They're on hand to answer questions and offer support to pharmacy owners right across our patch, so do reach out to them.
Yes, and today our focus is really getting to grips with the patient group directions, the PGDs that, guide the treatment for these infections. We're going to look really closely at the inclusion and exclusion criteria. Understanding these inside out is, well, it's key to making sure we can support our patients safely, effectively using Pharmacy First.
Absolutely. Couldn't agree more. We've got 3 specific PGDs to look at today, haven't we?
That's right. One for flucloxacillin, one for clarithromycin, and then the third one is for erythromycin, specifically for pregnant individuals.
And understanding the sort of fine details of these criteria, it isn't just important, it's fundamental, really, for providing the best care through Pharmacy First. So should we start by unpacking the flucloxacillin PGD?
Sounds good. So for flucloxacillin, the first inclusion point is age. The patient needs to be 1 year old or over.
Okay, 1 year plus. Got it.
And then, obviously, there needs to be a diagnosis of an infected insect bite or sting. And critically, this diagnosis has to line up with the nice clinical knowledge summaries, the CKS guidance.
Right, so not just any old bite that's red and itchy. We need proper signs of infection based on those guidelines. What are the key signs we should be looking for?
Okay, so the PGD specifies that the infection itself needs to be present or clearly getting worse for at least 48 hours after the bite or sting happened. That's quite specific.
48 hours later.
Yeah.
Okay.
And crucially, you need to see 3 or more of these signs. Redness around the bite, remembering, of course, that can be harder to spot on darker skin tones. Pain or tenderness when you touch the area, noticeable swelling, and the skin feeling, unusually hot.
Okay, so 3 of those.
Mm-hmm.
Redness, pain, swelling, heat. And they've got to be sticking around or worsening after 2 days. Is that everything for inclusion?
Almost. There's one more bit. Alongside having at least 3 of those signs I just mentioned, the patient also needs to have one of the following. Either the redness or swelling is clearly spreading outwards from the bite, or you see pustular discharge, pus basically, coming from the bite site.
Got it. So it's the local signs plus that extra element of spreading or pus.
Right.
Now let's flip that. When is flucloxacillin not the right call? The exclusion list looks pretty long.
It is quite detailed, yes. And that's really all about patient safety, making sure flucloxacillin is only used when it's appropriate and safe. So first off, as you'd expect, anyone under 1 year old is excluded. If the patient or their parent or guardian refuses consent, we can't proceed. That's fundamental. And for anyone under 16 who is pregnant, or even if you just suspect they might be pregnant, flucloxacillin isn't appropriate under this specific PGD.
Right, especially as we've got that separate PGD for pregnancy coming up later. What about patients whose immune systems might be compromised?
Yes, severely immunosuppressed individuals are excluded. The PGD points us towards Chapter 28A of the Green Book for the precise definition. The really key thing to grasp here is that in someone immunosuppressed, even a seemingly minor infection like a bite it can escalate very quickly. And the usual antibiotic choices might not work as well, or they could carry different risks. That's why the Green Book is so specific.
Okay.
Examples include things like certain leukemias, aggressive lymphomas within 12 months of cure, patients being followed up for chronic lymphoproliferative disorders, HIV with a CD4 count under 200, stem cell transplant recipients within the last 24 months, or maybe longer if they're still on immunosuppression or have graft versus host disease.
That's a really vital point about things potentially getting worse quickly.
Yeah.
What about medications that suppress the immune system? That must cover quite a lot.
It really does. The exclusion covers people currently getting or who've had immunosuppressive chemotherapy or radiotherapy within the last 6 months. Also, immunosuppressive therapy for a solid organ transplant within that same 6-month window.
Okay.
Then you've got targeted therapies for autoimmune diseases within the last 3 months, things like JAK inhibitors, biologics, B-cell therapies like rituximab rituximab, TNF inhibitors, various IL inhibitors. It also covers chronic immune-mediated inflammatory diseases where patients are on certain immunosuppressants like moderate or high-dose corticosteroids for specified times, non-biological oral agents like methotrexate, azathioprine, mycophenolate at certain doses, certain combination therapies too, like prednisolone over 7.5 milligram with other immunosuppressants or methotrexate with leflunomide within 3 months, and even short courses of high-dose steroids, say over 40 milligram prednisolone for more than a week in the last month.
Wow, that's incredibly specific. It really shows how careful you need to be with medication history.
Absolutely. When in doubt, you really need to delve into that history, maybe even chat with their GP if needed.
Okay. What about allergies? That's always top of the list with antibiotics.
Crucial, yes. Any known hypersensitivity to flucloxacillin itself or to any other penicillin or even to any of the inactive bits in the formulation, that's a definite exclusion. And also, if there's a history of a severe immediate hypersensitivity reaction, think anaphylaxis to another beta-lactam like a cephalosporin or carbapenem, that also rules out flucloxacillin here.
Right. Makes sense. And what if someone just struggles taking tablets or capsules for other reasons?
Good point. If the patient simply can't absorb oral meds properly or they physically can't swallow tablets or capsules, then flucloxacillin in those forms won't be suitable. And interestingly, the PGD also excludes people who are currently on a ketogenic diet.
Oh, that's one you might not immediately think of. Why is that?
Well, it highlights how we need to consider the whole picture, doesn't it? Flucloxacillin is metabolized in the liver, and there's a sort of theoretical risk, a potential risk of increased ketone production in someone already on a ketogenic diet. It could potentially worsen their metabolic state. It's a specific precaution.
Huh. Good to know.
Yeah.
What if they've already had an antibiotic for this bite and it didn't clear it up?
Yeah. If a previous antibiotic course has failed for this current bite infection, then using flucloxacillin under this PGD isn't the right next move. Also, anyone you suspect might be having a systemic allergic reaction right now, like angioedema, that swelling of the face, lips, tongue, or anaphylaxis, they're excluded and need urgent attention.
Right, immediate referral.
And the same goes if they have a history of a previous systemic allergic reaction to the same type of bite or sting.
Okay, so past reactions matter too. What about other underlying health conditions?
Yes. Several conditions are listed that could complicate things or slow down recovery. Peripheral arterial disease, chronic venous insufficiency, lymphedema, morbid obesity. These are all exclusions. Also, flags like severe pain that seems way out of proportion to how the bite looks, that could signal something more serious underneath. Significant fluid or pus collection might need draining, not just antibiotics. And numbness or tingling around the bite area is another exclusion.
So basically, if the local signs seem unusually severe or complex, think again. What about if it just doesn't look clearly infected?
Exactly. If there's no clear evidence of actual infection, maybe it just looks like that initial inflammation you get with any bite, something that self-care should sort out, then antibiotics aren't indicated under this PGD. We also need to think about what caused the bite. Human or animal bites or scratches, they're out. Different bacteria potentially need different drugs. Bites or stings inside the mouth, throat, or around the eyes. Too risky, need specialist assessment, so they're excluded. And puncture wounds, if they've got freshwater, seawater, soil, or manure contamination, risk of different bugs, maybe tetanus risk too, so
Absolutely. But does it matter where the bite happened?
It does. If the bite or sting occurred outside the UK, there's a chance of unusual infections needing different treatment, so that's an exclusion. Same if the bite, even if it happened here, was from an unusual or exotic insect.
Okay.
And tick bites, or anything that looks like it could be a tick bite, maybe they mentioned walking in long grass, excluded because of the Lyme disease risk, that needs specific management.
And the classic bullseye rash?
Definitely. Evidence of erythema migrans, that bullseye rash, means it's likely Lyme disease, so excluded from this PGD.
So lots of things pointing towards needing a different diagnosis or management route.
Yeah.
What if the person just seems generally unwell?
That's a big red flag. If the patient seems systemically unwell, fever, chills, feeling really rough, or if there are any signs suggesting a severe infection or even sepsis brewing, that's an urgent ambulance to A&E referral. They are absolutely excluded from the PGD.
Okay.
A history of previous or current MRSA infection is also an exclusion. And anything related to liver problems, previous or current liver disease, or if they've specifically had jaundice or liver issues linked to flucloxacillin before they can't have it under this PGD.
Liver health seems quite key then. Kidney function too.
Yes. Known chronic kidney disease stage 5, that's an eGFR below 15, they're excluded. And we also need to be careful with people at risk of high anion gap metabolic acidosis. This could be due to things like malnutrition, sepsis, existing kidney problems,
Yeah.
especially if they are currently taking or have recently taken paracetamol.
That's a very specific interaction with paracetamol to watch out for. Why is that?
Well, in those particular vulnerable individuals, high doses of paracetamol could potentially contribute to or worsen that high anion gap metabolic acidosis. It's a serious condition. Flucloxacillin itself has, although rarely, been linked to it too. So using them together in someone already at risk just increases that potential risk, hence the exclusion.
Right. That's a really important safety point. Any other exclusions around vaccines or other medicines?
Yes. Oral typhoid vaccine, if they've had it less than 3 days before or are due it within 3 days after the consultation, they're excluded. And finally, using any medicines concurrently that are known to interact with flucloxacillin, the PGD, lists these. That's also an exclusion. Think methotrexate, probenecid, that oral typhoid vaccine again, and paracetamol in those specific at-risk patients we just mentioned.
Okay, so a really, really thorough check of all current and recent meds is absolutely non-negotiable before using this flucloxacillin PGD.
Right, that covers flucloxacillin in detail. Let's move to clarithromycin. This is our alternative if flucloxacillin is out due to penicillin allergy, right? Exactly that. So the inclusion criteria for clarithromycin, largely the same. Patient needs to be 1 year or older.
Okay.
Diagnosis of infected insect bite or sting based on NICE CKS guidance, same as before. And those same clinical signs of infection we talked about present or worsening for 48 hours plus. Redness, pain, swelling, heat. Plus either spreading redness, swelling, or pus.
So the infection criteria are identical. The key difference then is purely why you choose clarithromycin.
Precisely. The crucial additional inclusion point for the clarithromycin PGD is a known hypersensitivity to flucloxacillin, any other penicillin, or any component of the flucloxacillin formulation. Or, alternatively, that history of a severe immediate hypersensitivity reaction to another beta-lactam, like a cephalosporin. If they have that documented allergy and meet the infection criteria, then clarithromycin comes into play.
Perfect sense. Penicillin allergy confirmed, infection meets criteria, clarithromycin is the potential option. Okay, what about exclusions for clarithromycin? Any major differences from flucloxacillin?
There's quite a bit of overlap, yes, but also some really important differences and extra things to look out for, like flucloxacillin, under ones are out, refusal of consent is out. But pregnancy or suspected pregnancy is listed as an exclusion here without the under 16 limit we saw before. That's because there's the separate erythromycin PGD for pregnancy.
Ah, okay, that's a key difference on pregnancy. What about immunosuppression? Same definition.
Yes, the severely immunosuppressed exclusion, referencing Chapter 20A of the Green Book, is exactly the same definition as for the flucloxacillin PGD.
Okay, good. So that complex list applies to both. What about allergy to clarithromycin itself?
Absolutely. Known hypersensitivity to clarithromycin or any other macrolide antibiotic or any of the inactive ingredients in the clarithromycin product, that's a definite no. Also, if someone's already on long-term clarithromycin or another macrolide, they're excluded too. Partly resistance, partly interaction risks.
Logical. Any other exclusions unique to clarithromycin?
Yes, a few specific ones. Patients with known myasthenia gravis are excluded. Anyone with a known history of QT prolongation, that heart rhythm issue, or a history of ventricular cardiac arrhythmia, including that specific type called torsades de pointe, shouldn't get clarithromycin under this PGD.
Right, the QT interval, that measure of the heart's electrical recharging time. Clarithromycin can affect that.
It can, yes. And because of that potential effect, taking other medicines that also prolong the QT interval is another exclusion. The PGD gives examples like haloperidol, sotalol, terfenadine, pimozide, and it advises checking resources like Credible Meds or SADI's information for, a fuller, up-to-date list.
Good tip.
Also, known electrolyte problems, low potassium, hypokalemia, or low magnesium, hypomagnesemia, are exclusions, as they can increase the risk of QT issues too.
So a really careful check of cardiac history and all current meds is vital before thinking about clarithromycin. Any specific kidney or liver exclusions for this one?
Yes. For kidneys, chronic kidney disease stages 4 or 5, so an eGFR below 30, is an exclusion for clarithromycin. That's a slightly wider exclusion than flucloxacillin stage 5 only.
Okay, eGFR 30 for clarithromycin.
And for the liver, A previous history of jaundice or liver problems linked specifically to macrolides, or any known or suspected severe liver disease, ruled out clarithromycin.
Got it. Both kidney and liver checks needed, with slightly different thresholds. Any other heart conditions?
Yes. Known heart disease like coronary artery disease, severe heart failure, or a really slow heart rate, bradycardia below 50 beats per minute. That's another exclusion for clarithromycin.
Okay. And what about other interacting meds or vaccines, like we saw with flucloxacillin?
The oral typhoid vaccine exclusion less than 3 days before or within 3 days after that still applies here. And yes, there is a pretty long list of interacting medicines that exclude someone from getting clarithromycin under this PGD. It includes simvastatin and levastatin, estemazole, cisapride, deperidone, pimozide, terfenadine, ergotamine, dihydroergotamine, ranolazine, ticagrelor, colchicine, oral midazolam. The oral typhoid vaccine again, any other QT prolonging drug, and strong CYP3 are inducers, things that speed up clarithromycin metabolism like efavirenz, nevirapine, rifampicin, rifabutin, phenytoin, carbamazepine, phenobarbital, St. John's wort.
That is a hefty list of interactions. It just hammers home how vital that thorough medication history is before touching this PGD.
Ugh.
Okay, flucloxacillin covered. Clarithromycin for penicillin allergy covered. Let's talk about the third one, erythromycin, specifically for pregnant individuals.
That's right. This one's tightly focused. Pregnant individuals age 16 or over with a suspected infected insect bite, and where flucloxacillin is out due to confirmed penicillin allergy.
So very specific circumstances. What are the inclusion criteria?
They mirror the others again, mostly. Diagnosis of infected insect bite via NICE CKS. Those same clinical signs, redness, pain, swelling, heat present or worsening for 48 hours plus, and either spreading redness, swelling, or pus. The key additional inclusions here are confirmed or suspected pregnancy, and that documented known hypersensitivity to flucloxacillin penicillin or severe immediate reaction history to another beta-lactam.
So same infection signs, same penicillin allergy requirement, but specifically in someone pregnant and 16 or over.
Right. Exclusions for erythromycin in this group, similarities again.
Yes, lots of similarity, but again, some important differences relevant to pregnancy or erythromycin itself. Under 16s are out, refusal of consent is out. The severe immunosuppression definition from the Green Book still applies. And obviously, known hypersensitivity to erythromycin itself, any other macrolide or any inactive ingredients rules it out.
Okay, what about pre-existing conditions that might make erythromycin risky during pregnancy? Well, those comorbidities that might complicate things, peripheral arterial disease, chronic venous insufficiency, lymphedema, morbid obesity, there's still exclusions here. Inability to absorb or swallow oral meds, ketogenic diet, failed previous antibiotic for this bite, those still apply too. And all those exclusions related to systemic reactions, severe pain, pus fluid, numbness, no clear infection, the type of bite, human, animal, etc., location, mouth, eyes, contamination, travel, unusual insects, tick slime, being systemically unwell or septic, MRSA history, those all carry over from the other PGDs pretty much.
So many of the same, this looks more serious or different. Red flags still apply. What exclusions are more specific to erythromycin or pregnancy?
Okay, so current long-term use of erythromycin or another macrolide is an exclusion. Same reasoning as before. Known porphyria, that group of genetic disorders, is an additional exclusion specifically for erythromycin. Also, taking any medicines at the same time that are known to be potentially hepatotoxic liver damaging. The PGD says check the SBC or liver tox database for specifics there.
Liver safety again. What about heart conditions in a pregnant patient?
Yes. Known heart disease, coronary artery disease, severe heart failure, conduction problems, or that slow heart rate, bradycardia below 50, these are exclusions for using erythromycin under this PGD in pregnancy.
Okay, and interacting meds or vaccines for pregnant patients on erythromycin?
Yes. Oral typhoid vaccine timing exclusion still applies. And there's another list of interacting medicines that rule out using erythromycin under this PGD during pregnancy. This includes simvastatin, tolterodine, amisulpride, estemazole, cisapride, misolastine, domperidone, pimozide, terfenadine, ergotamine, dihydroergotamine, chloroquine, hydroxychloroquine, colchicine, ivabradine, oral typhoid vaccine again, any other QT prolonging drug, strong CYP3A4 inducers like rifampicin, phenytoin, carbamazepine, phenobarbital, St. John's wort, and also direct oral anticoagulants, other statins, calcium channel blockers, digoxin, and drugs known to cause low potassium levels, hypokalemia.
Another really extensive list. Just reinforces that need for meticulous medication review, even in this very specific group.
It really does. It just highlights time and again, careful assessment, accurate history, taking absolutely crucial to apply these criteria correctly and safely.
Okay, we've really gone through the fine print of all 3 PGDs for infected bites now. What are the main sort of overarching takeaways for pharmacy teams using these day to day?
I think the absolute number one thing is that thorough, accurate patient assessment. Getting that detailed medical history, medication history is paramount. Without that full picture, allergies, current meds, conditions, you simply can't apply these detailed criteria safely.
And it really strikes me, allergies and drug interactions are 2 areas you just have to double check every single time, meticulously.
Precisely. You've got to check for known allergies, not just to the antibiotic itself, but related classes, inactive ingredients, and that check for potential drug interactions before supplying anything. Non-negotiable. It's fundamental patient safety.
In documenting everything.
Oh, absolutely essential. Detailed, accurate records. What you found in assessment, the advice you gave, any referrals made, it all needs to be clearly documented in the patient record. Good for continuity, good for audit trail.
And even if someone doesn't actually meet the criteria for an antibiotic under the PGDs, the pharmacy team still has a really important role, don't they?
Absolutely. Whether you supply an antibiotic or not, providing that clear safety netting advice is vital. Information on self-care, what they can do themselves, but also really clear guidance on when and how to seek more help if things don't improve or if they get worse.
And if someone is clearly excluded from all 3 PGDs, what's the next step?
The PGDs outline the referral pathways. If they're excluded, but you think antibiotics might still be needed, or they just need further review, but it's not, an emergency, then referral back to their GP is the right move. But, and this is critical, if you spot any signs of severe infection, systemic sepsis, anything life-threatening, it's an immediate, urgent referral to A&E via ambulance. That's mandated.
And just to be crystal clear for everyone listening, these PGDs we've discussed are specifically for use within the NHS England-commissioned Pharmacy First service.
That is absolutely correct. They operate within the framework of that specific national service.
Well, this has been a genuinely deep dive into those inclusion and exclusion criteria. It really brings home just how much detail pharmacy professionals need to be on top of for safe and effective care with infected insect bites.
It does, and it really underscores the level of responsibility and the clinical skill that community pharmacy teams are bringing to managing these common conditions through Pharmacy First. It's significant.
And one final reminder for all pharmacy owners and your teams across Oxfordshire, Berkshire, and Buckinghamshire. Community Pharmacy Thames Valley is there for you. Please don't hesitate. Reach out if you have questions, need clarification, need any help at all with these PGDs or anything else Pharmacy First related. They're a fantastic local resource.
Definitely. Pharmacy First offers such a valuable, accessible way for patients to get timely care for these bites right in their community. And pharmacists are pivotal, applying these criteria accurately, consistently. Ultimately, it's about patient safety and getting the best treatment outcomes.
Thank you so much for joining us and walking us through all of that.
Yeah.
We really hope this has given you, our listeners, the clarity and maybe the confidence boost needed to keep using Pharmacy First effectively for your patients. And perhaps it leaves you thinking, with such detailed guidance, even for relatively common things like infected bites, how can we all best stay current and navigate this ever-changing clinical landscape to ensure we're always offering the absolute safest and most effective care?
That's certainly a crucial question for all of us in practice, always.
Indeed. Until our next deep dive, thank you for listening.